Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, PEAK, a randomized multi-center phase 2 study of panitumumab plus mFOLFOX6 or bevacizumab plus mFOLFOX6 in patients with previously untreated, unresectable wild-type KRAS exon 2 metastatic colorectal cancer by Lee Schwartzberg et al. My name is Thomas Abrams, and I'm an instructor in medicine at the Dana-Farber Cancer Institute and the Harvard Medical School in Boston, Massachusetts. My oncologic specialty is medical oncology with a focus in GI malignancies. In this podcast, I'll discuss first-line usage of anti-EGFR therapies in metastatic colorectal cancer in the context of the PEAK trial findings, with a focus on emerging data surrounding RAS oncogene mutations in treatment selection. Metastatic colorectal cancer remains a major health problem worldwide. In the United States alone, there are approximately 143,000 cases of colon cancer diagnosed annually, with over 50,000 deaths from advanced disease. However, the average overall survival of patients with the disease has improved dramatically over the past decade, due in large measure to the development of novel agents, including those that target the epidermal growth factor receptor. Anti-EGFR monoclonal antibodies, such as cetuximab and panitumumab, have been shown in multiple randomized clinical trials to improve both progression-free and overall survival in patients with metastatic colorectal cancer whose tumors are free from mutations in KRAS, i.e. KRAS wild-type tumors. For instance, in the phase 3 CRYSTAL study, 1,198 treatment-naive patients were randomly assigned to receive FOLFIRI with or without cetuximab. In patients whose tumors were KRAS wild-type, overall survival, progression-free survival, and response rates were significantly improved in the cetuximab arm. In the PRIME trial, 1,183 patients with untreated metastatic colorectal cancer were randomized to receive FOLFOX with or without panitumumab. In the KRAS wild-type stratum, median progression-free survival was significantly improved in the panitumumab arm. While overall survival only trended toward improvement in the initial analysis, an updated analysis showed a statistically significant median overall survival benefit of 4.4 months for KRAS wild-type patients on the panitumumab arm, p equals 0.03. Other studies, such as the UK MRC COIN trial and the Nordic 7 trial, failed to show a progression-free or overall survival benefit from the addition of cetuximab to oxaliplatin-based chemotherapy in their KRAS wild-type cohorts. KRAS exon 2 mutations are present in approximately 30 to 50% of metastatic colorectal cancer cases and are by far the most common of the RAS oncogene mutations in the disease. Lower frequency RAS mutations are also clinically relevant. In a subsequent analysis of the PRIME data, 17% of the tumors, n equals 108, that were KRAS exon 2 wild-type were eventually found to harbor mutations in KRAS exons 3 or 4 or in NRAS exons 2, 3, and 4. Like KRAS exon 2 mutations, these lower frequency RAS mutations also predicted a lack of response to panitumumab. In the PEAK trial, Schwartzberg et al. Randomized treatment-naive patients with KRAS exon 2 wild-type tumors to receive FOLFOX and bevacizumab, an anti-VEGF antibody, or panitumumab. As the authors noted in their manuscript, PEAK is the first randomized trial to compare the treatment effect of an anti-EGFR antibody to an anti-VEGF antibody in combination with an oxaliplatin-based chemotherapeutic regimen. In all, 285 patients were recruited between April 2009 and December 2011, and almost all received treatment. The primary endpoint was progression-free survival, with overall survival as a secondary endpoint. The investigators also pre-specified an extended RAS gene analysis, including exon 2, 3, and 4 of KRAS and NRAS exon 2, 3, and 4. Median progression-free survival was not significantly different between the two arms in the PEAK trial, 10.9 months in the panitumumab arm and 10.1 months in the bevacizumab arm. However, overall survival was greatly improved in the panitumumab arm, with median overall survival of 34.2 months versus 24.3 months in the bevacizumab arm. P equals 0.0009. Patients in both arms received a median of 12 cycles of either panitumumab or bevacizumab, although FOLFOX dose intensity was slightly less in the panitumumab arm. The most common reason for ending treatment was disease progression with adverse events leading to discontinuation, and 24% of patients in the panitumumab arm and 27% of patients in the bevacizumab arm. Subsequent chemotherapy exposure, i.e. second line, was similar in both arms. Of the 221 tumor samples that could be evaluated for an extended RAS analysis, 51 or 23% were mutated in other areas of KRAS, exons 3 or 4, or in NRAS. The rest, 170, were RAS wild type, and analyses confined to this population showed a progression-free survival improvement in the panitumumab arm of 4.5 months, P equals 0.029. Additionally, the median overall survival benefit was extended in this predefined RAS wild-type subpopulation to 41.3 months in the panitumumab arm and 28.9 months in the bevacizumab arm. Still, this difference in overall survival between the two arms fell just shy of statistical significance due to the relative small size of the trial. Crucially, the puzzling result of dramatically improved overall survival with minimal or no improvement in the progression-free survival seen in PEAK was mirrored in the FIRE-3 study, a phase 3 trial in which KRAS exon 2 wild-type patients with untreated metastatic colorectal cancer were randomized to receive either cetuximab or bevacizumab along with FOLFIRI. As in PEAK, there was no statistical difference in progression-free survival between the two arms, but overall survival was significantly improved in the cetuximab arm, 28.8 versus 25 months, with a p-value of 0.0164. The results of PEAK offer provocative data suggesting that first-line treatment with an anti-EGFR antibody in conjunction with chemotherapy could be a preferred choice for metastatic colorectal cancer patients with wild-type KRAS tumors. While the effect on progression-free survival may have been negligible, there was a significant improvement in overall survival when compared to FOLFOX and bevacizumab. While it is indeed difficult to square the lack of progression-free survival to the significant overall survival benefit, it is reassuring to know that the FIRE-3 results are virtually identical despite a different chemotherapy backbone, FOLFIRI, and a different anti-EGFR antibody, cetuximab. Further inquiry into the possible reasons for such unexpected findings are clearly needed, including defining the impact of second- and third-line therapies following either first-line anti-EGFR or first-line bevacizumab therapies. Such work will hopefully lead to a deeper understanding of the complex interactions of drugs across various lines of therapies and across various tumor genotypes. Finally, and no less importantly, we eagerly await the imminent results of CALGB 804005, the largest clinical trial to compare first-line anti-EGFR and bevacizumab therapies. The PEAK study results also highlight the critical role of lower-frequency RAS mutations. If, as the PEAK data suggest, KRAS mutations in exons 3 and 4 and NRAS mutations confer at least some degree of resistance to anti-EGFR antibodies, our current standard of testing only for mutations in KRAS exon 2, codons 12 and 13, is insufficient. By expanding our palette of routine mutational testing, we will be closer to realizing our goal of truly personalized medicine. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.